All right. Well, hello, everybody. We're back with another Facebook Live. And today you notice we have a lot more people. Today we have Alyce Adams. She is the Kegel Queen, and she's a registered nurse and our guest expert today. We also have Hannah, who many of you have never met before. Hannah is our latest coach at Adele LLC, and she has a background in nursing. She's also an NASM personal trainer and certified nutrition coach. And y'all know Tiffany, NASM, it's NASM, right? Nutrition coach,
yeah.
Personal trainer. So we're all here today. So welcome Alyce, welcome Hannah, Tiffany. It's great to have you here. I just want to fill you all in a little bit on Alyce's background. She is a registered nurse. And as I mentioned, she is our guest expert today. She's known as the Kegel Queen. I actually had to look that up. I was like, how do you pronounce Kegel? Because my whole life I pronounced it Kegel.
And that's not incorrect. It's fine.
Oh, okay. All right.
Matter. You can still say it that way.
Okay.
I met somebody who said they had met Arnold Kegel, or they knew people who had met him or something, and they said Kegel. Now, I don't love that it's named after a male doctor, but that's what they're called.
Yeah, okay.
Apparently
so
pronounced it Kegel, so that's what I say, but this,
gotcha.
no judgment for Kegels here.
All righty, thanks. So Alyce founded kegelqueen.com in 2009. So she has been doing this for a while. This is her wheelhouse. She's known as the most sought after Kegel exercise expert around the world. She helps women who suffer with vaginal prolapse or urinary incontinence to avoid dangerous surgery and regain their health and control of their body down there. So she's famous. You know, she has created the Kegel Success in Minutes a Day program, and it's the only complete, no devices, safe at home Kegel exercise program created and tested by an RN. And her program has reached over 3,580 women in over 30 countries around the world. She shared her Kegel exercises or expertise as a guest blogger for the American College of Nurse Midwives, and she's a guest lecturer at Bastyr University in Seattle and the University of Rochester in New York. And most recently, Alyce has consulted with the Stanford Biodesign Fellowship at Stanford University in California. Alyce lives in Rochester, New York. So welcome, Alyce. We're really excited. I think you are our first guest expert in a Facebook Live.
Wow, that's an honor. Thank you so much for having me.
I'm just going to say real fast, that list of everything that you've done and accomplished is pretty impressive. I might be slightly intimidated right now, but it's okay. It's cool. I'll be a girl. It's okay.
I'll try to be nice.
Okay, thank you. I appreciate that.
You are nice. It just comes naturally. So maybe Alyce, can you tell us what pelvic organ prolapse is? Because I am not too familiar with this, and not having had children myself. Tiffany has had 4. Hannah, how many babies do you have?
I have 3.
3. Okay, so this is a topic you ladies are familiar with, and many people in our Facebook group, members of our audience, are familiar with this, but let's pretend like I know nothing. Can you tell me what it is?
So just for the record, it happens also for women who've never had children. That's common, but it certainly does happen, particularly after menopause, for women who have not had children. So here's our pelvic model. This is going to be our best friend today while we're talking, and hopefully it doesn't, sometimes it kind of, the pelvic floor part falls off. So let's hope that doesn't happen. So
let's hope that doesn't happen in real life either.
Right, that's right.
Yeah.
So this is a female pelvis, and all of this stuff is the pelvic floor. So just to get oriented, pelvis is at an angle like this in the body. And in here, in this pelvic bowl, live your pelvic organs, your bladder, your uterus, and your rectum. And when one or more of those organs literally falls out of its proper place, that's pelvic organ prolapse. So those organs are supported from behind and below by these muscles, by the pelvic floor, from the sides and top by ligaments, And when one or both of those systems fails to provide the support that those organs need, they fall, literally fall. And if you get oriented here, here we have the vagina, anus, right? So in here, there we go. There's this natural gap in the muscle where the vagina and urethra pass through. And those organs literally fall through this gap in the muscle. So it can be really mild and be just like a little tiny bulge in either the front or the rear wall of the vagina, or the cervix, the tip of the uterus can be lower than it should be. That can be mild in a way that you don't even know is happening, or it can be so severe that there's a large bulge of the vaginal wall with an organ behind it, or the cervix and uterus itself coming out through the vaginal opening. So that's what pelvic organ prolapse is. You can also have, in addition to one of those three organs, it can also sometimes be a loop of small intestine coming through.
I had heard of this from, I wouldn't say she was a friend, but somebody I knew who donated to women in Africa who had this and they couldn't have surgery. And she told me some of these women have their organs coming out between their thighs. Like, it's so severe, this problem. So what you're doing, I think, is just, it's so important. And I had never heard of this sort of thing before, but it's more common than many people know.
It's extremely common. And I'm so happy to be here and speaking, because even for me, I went through nursing school. Before nursing school, I'd spent a decade in women's health, working on all kinds of birth and postpartum stuff. Then I went through nursing school. I got halfway through a master's degree in midwifery before I left school to have my own baby. And I barely knew what prolapse was.
Wow.
This is something that is so under-discussed and that women don't talk to each other about. The same women who tell each other everything about their marriage and their hopes and dreams and whatever. If something is going wrong with their vagina, this particular thing especially, they often don't say a word. Sometimes they don't talk to their doctors. So I'm really glad we're talking about it to get some awareness out there.
And they don't talk about it because there's a sense of shame.
That's the main thing. Yeah. And they think they're alone. So
right.
Back to what you were saying before, if you examine women, some of them might not have any symptoms, but 50% of women will have some form of prolapse.
Wow, 50%.
After menopause, as time goes by, if you examine 20-year-olds, it's not going to be the same. But if you examine, say, 60-year-olds, 50%. And then the other numbers are different. A lot of people say 20%. Some studies show with symptoms, some say less. But the alarming statistic is that 1 in 5 in the United States, 1 in 5 women will have surgery to address pelvic organ prolapse or urinary incontinence by the time she's 80 years old. 1 in 5. But we haven't even heard of it. So what's with that? And and we can talk about this later, but the other thing I need people to know before you go get your lunch or whatever, hear that surgery is not the only option for prolapse.
We'll talk about your options a little later in the call. So make sure you guys stay tuned so that you can learn more about that. And if you ever have any questions, I am monitoring the comments. So feel free to pop any questions in there and we can throw them in as we can fit them in. Okay.
Hannah, did you have a question at all?
No questions so far. I totally agree.
Okay.
Just from what I've seen in my own professional practice as a nurse, of all ages. I mean, I've had patients with organs between their legs and at an advanced age. And I've also dealt with a lot of mamas that have early symptoms of this type of thing, And I am very vocal with my girlfriends about this because I believe it's very under addressed, like you said, Alyce. And I have 7 sisters, so I am also the go-to, like, I talk to my sisters about this stuff because I believe women need to feel more comfortable talking about these tough things, because they suffer in silence and they think they're alone. I think that's the biggest thing. It's like embarrassing. And so I'm trying to normalize it in my circles, because if women don't know that it's normal, they can't be released from that shame and then get help. Because if it's a topic they can talk about and be comfortable talking about, then they can get the help that they need before it's too advanced. Or I mean, maybe too advanced is an extreme thing to say, but I think a lot do wait like a
Well,
really long time and suffer.
yes, and that, I mean, again, we can talk about this later, but it's like anything else with your health. If you catch it early and you take measures, it's a very different scenario than if you do nothing. And I think
Yeah.
that's an enormous way that the conventional treatment has really failed women with this particular issue.
I have a question. Like, so back at the very beginning, you told me something that I didn't know, which is women can have this issue even if they've never had children. So I always thought there was a mechanical reason for it. But when you talk about ligaments and things like that, now I'm thinking there could be nutritional gaps. It could be muscular atrophy and things like that. Even if you've not had children, you can get this. So I would like to know, what are some of the key but sometimes subtle signs of pelvic floor issues?
So, well, one thing to know is if you're getting a GYN exam, you're going in for your regular pap smear or whatever, very often your provider is going to notice a little prolapse that you're not aware of and not say a word, because in their world, it's common, there's nothing to do about it, which is incorrect, but in their world, there's nothing to do about it because it's not bad enough for surgery yet. So often they don't mention it. So when you're having a GYN exam, ask, do you see any signs of any prolapse? That's one thing. And to be alert for any changes with your and we were talking earlier, you can have your pelvic floor issues can take a couple different forms, right? The pelvic floor can be too lax and not doing its job properly because it's too loose, or it can be too tight and not doing its job properly because it's too tight. So either way, if it's too loose, you might have trouble holding your urine, you might have trouble controlling your gas. You might have, you might be prone to air going in your vagina, like if you downward facing dog. You might find, like, I'm so uncomfortable right now, there's like air going into my vagina. You might feel like a heavy or sagging sensation. If the pelvic floor is too tight, you might have trouble starting your stream of urine. You might have constipation. I mean, there are a lot of different reasons for constipation, of course. You might have pain with intercourse. You could end up with, you might not have any sensations or symptoms in your pelvic area at all, but you might have a domino effect going up your back, because here, the pelvic floor is connected to the base of your spine, right? Here's your tailbone, here's your sacrum, and right above the sacrum, of course, is your lowest vertebra. So your whole spinal column is affected by your pelvic floor, and you may have back issues that could be helped a lot by optimizing your pelvic floor.
Wow.
So it does a lot of things. And then other kinds of sexual dysfunction too. You might have reduced sensation, or if the pelvic floor isn't, if those muscles aren't strong and healthy and well nourished with good circulation, you might have a harder time with sexual function. Could be a lot of things.
A lot of things. But if you're getting an exam, you can ask those questions and then decide what to do with that information.
I mean, what you could learn in an exam, and I'd be interested to hear what you want to say about that, Hannah, but again, asking, do you notice any prolapse? And you can also ask the provider to test your pelvic floor tone,
Oh,
ask for their opinion, what,
I've never heard of that. Wow.
how, if they want to test, they put their two fingers in your vagina and you squeeze, you do your best pelvic floor contraction, and they might be able to tell you, how's the contraction? How's the relaxation? What do they sense about, is it tight or loose?
So I'm thinking to myself, what's the training for that like in med school?
Well,
Because you
in
have to do
midwifery
a lot
school,
of patients to figure out what's normal tone and clenching and stuff like that.
in
But
midwifery school, we're each other's models. It's a little
wow.
socially awkward, but
Wow.
oh.
I'm learning so much already. This is amazing.
And Hannah, do you have comments about that? About, what you see clinically as far as or comments about how to help women engage with a pelvic exam actively to get good information?
Yeah, I think that you're saying it already. Like, it's just, I always come back to information. They have to understand what they're looking for going into an exam. A young woman, old woman, whatever age group needs to understand what questions to ask. I see a lot, and Alice, I know you've seen this, that a lot of patients or people are intimidated to ask questions. They just let the exam go and they don't ask questions. They don't, if a doc says, oh, yeah, maybe. Like, maybe they do know to ask, and the doctor says, oh, it's just a little bit. Don't even worry about that. That's not something we need to address right now. Well, they go on their merry way and have no idea what other options are there, right? So, like, I have just seen, and I tell my patients on a daily basis, like, do you understand what you're being told? You have options, ask questions, and because you can see like that deer in the headlights look, and they are like, and they have no idea what somebody just said to them. So it's just really important to make sure that we are informing audiences in our circles and just doing our best to get the word out there, because really it just comes down to having enough information to know how to take the next step.
You have to advocate for your own health in life in so many ways. That's been my own journey with Hashimoto's, and now I'm hearing this, but sometimes you don't even know what questions to ask.
Right.
So I really appreciate you sharing that, Alyce. I mean, that was huge for me personally. Many women think that peeing while sneezing and coughing and exercising as they age is normal, or after childbirth, it's normal. Do you have anything to say about that specifically?
It's a big difference between common and normal.
Mm-hmm.
These days, particularly after the pandemic, depression is common. It's not normal.
Right.
So yeah, one of the things that I see a lot with women in my program and with people I know in my life, people have an expectation of, with aging, that they're not going to be as healthy.
Mm-hmm.
And I hear people say, like, whatever's going on, well, probably just aging. But there is no just aging. There's aging, and you might be more susceptible to certain things, you might be at higher risk for certain things, but there's no problem that automatically comes with aging. And I think it's critical that we have an expectation to be healthy, and that if things aren't really good, we investigate, that we hold that goal of really good health, and that we're not just accepting that.
Yeah.
I think that's a really, really important point, because I've heard so many times, oh, I can't do jumping jacks, I can't run, I can't do this. If I do, I'm going to pee myself. And even like, if you ever watch YouTube videos of people doing heavy workouts, like heavy deadlifts, heavy squats, you'll see videos of people urinating themselves. And I'm like, that's a sign either you're doing too much with that load, or there's something going on with your pelvic floor that is not normal, because you should not urinate yourself whenever you're in these day-to-day activities. It's not normal. And if it is experienced, if you are experiencing it, I do highly suggest that someone goes out and seeks professional help, whether it's online or in-person consultation. I will tell you, I know from experience how uncomfortable that in-person treatment can be, but it's extremely beneficial as well.
Mhm.
Is some of this hormonal? Because I remember when my dog got older and she started to pee herself, and the vet said, all right, give her a little bit of this estrogen every day, a little estrogen pill. And she
Dog
completely
estrogen.
stopped. Yeah, I was
I've heard of
absolutely
that.
shocked that that incontinence completely stopped. And I will say, like, I remember trying CrossFit and I did pee myself a little bit. And I'm like, what? You know, I think it was like a limited, it's not something I dealt with really, but it happened twice during CrossFit. And a decade later, I went on BHRT. I don't have any issues with incontinence during activity. And I do wonder, like, if estrogen plays a role in that as well.
Yeah.
Yeah.
Yeah, absolutely. And I mean, estrogen does so many things in the body. But one of the things it does is it keeps your connective tissue more elastic.
Mhm.
That's a big, big, big deal with everything in here. It's a big deal with everything, head to toe.
Yeah.
But your connective tissue is what keeps the fascia around your muscles elastic. It's what keeps your ligaments elastic. And yeah, it's a significant, significant thing. I think one thing that's very much under discussed too is our diet,
Mhm.
and our diet in our whole life.
Mhm.
Babies and teenagers make elastin, which is along with collagen, you all know. Along with collagen, it's a really important part of our connective tissue. But at my age, you can't really make elastin anymore. You might be able to preserve elastin. The same with collagen too. The quality of collagen is built in our whole lifespan. Um, and if, I'm for me, I'm 53, and I had a fine diet as a kid in the 70s, but it wasn't filled with bone stock on a regular basis. And there were other parts of my diet that I know now are actually damaging to connective tissue. And what I can do now is preserve, but
Mhm.
after about age 30, you can't really build your connective tissue anymore.
Mhm.
You can only preserve it. And I think paying really, really good attention to diet and making sure you get your collagen. Vegetarians, that's a whole other issue. But assuming you're not vegetarian, get collagen in your diet. And for everybody, antioxidants of all kinds. The whole, eating your vegetables really matters. It really, really does. And
Yeah.
not just your vegetables, but your spices and, your different kinds of tea, and even coffee has antioxidants in it, but really emphasizing those flavorful plant foods in your diet.
It's so crazy to me because we promote nutrition quite frequently, and we promote it for maintenance, muscle health, stuff like that. We know that nutrition has a role in basically everything, but you never stop to really think about how is it affecting my pelvic? Like, how is my nutrition affecting my sexual ability and my ability to pee? We do for the using the bathroom are going poop, but for sexual health and peeing, it's not really something that is common knowledge that specific things could potentially help in those situations.
Yeah,
Mhm.
absolutely.
It seems like really doctors treat with surgery, but there's a lot of approaches that you can use that are non-surgical. Do you have any that you can share with us?
Yeah.
Talked about nutrition.
Yeah. So, if you have pelvic organ prolapse and you suddenly go on a, bone broth and salad diet, your prolapse is not going to reverse because you're doing that. There's sort of that whole category of lifestyle stuff that's supportive. So that's one thing, is the supportive stuff such as diet. Then there's stop making it worse. And that includes things like being really cautious with your workout. Like, yes, if you jump on a trampoline, you shouldn't pee your pants. But if you are in the habit of jumping on a trampoline, you might put yourself at higher risk for peeing your pants. If you do CrossFit or you're doing certain kinds of core exercise, certain movements that increase the pressure, if you're increasing your intra-abdominal pressure, it creates pressure against your pelvic floor from this direction, and you can really blow out your pelvic floor. I have women come into my program and say, wow, all of a sudden, since I started XYZ workout, I'm having these problems. So there's that category. But then as far as treatment, actual like help for prolapse that isn't surgery, major tools to actually help. One is our Vigo therapy, which is a very gentle, pants on, underwear on at least, massage to the abdomen and pelvis, sometimes the hips, that helps to pull prolapsed organs back into their proper position.
Wow.
Practitioners are doing this all over the place now. It doesn't work for everybody, but it's certainly worth a try because it's very, very safe. But the big thing, the alternative to surgery, is a pessary. I have a whole set of them here, but I'll just show you one. You can see as many as you want, but this is a typical, the most common type. This is called a ring pessary with support. There are rings without support. There are like 25 different shapes of pessaries, and each one comes in a range of sizes. But the word pessary comes from Greek, meaning stone, because there's evidence of women from many, many centuries back using the right shaped rock in their vagina to hold up a prolapse. So nowadays we have these, probably a little more comfortable, but it's made of silicone. Many of them have metal inside here. So take note if you ever have an MRI or you go through an airport scanner or something.
Oh my goodness. Oh,
It's
jeez.
a flexible but stiff thing. This style is good for uterine prolapse and often for bladder prolapse, not as good for rectal prolapse, but sometimes it can work for that too. But this is the most likely, like if you go to the doctor or midwife and they're going to help you with a pessary, this is the most popular, common style. So this literally, you just wear it up at the top of the vagina, kind of like a contraceptive diaphragm, and it holds things up. There's more to it. We could talk for like 8 hours about pessaries. There's a lot to know about them, but that's a great, great, great tool.
Is
How long
that
do they
something
stay
that
in? Sorry. How long do they stay in typically?
Women, there's a range, and women work it out with their provider, but some women put it in occasionally. Some women put it in every day and take it out every night. Some women take it out twice a week. Some women wear them for up to 3 months or so without ever taking it out at all, and just have their provider take it out.
and that was going to be my question, is who applies it? Is it is it applied by a provider or is it self-applied? And you basically just answered that, saying it could be either.
Yeah, you need to have a fitting with a provider, and you need to have regular appointments so that someone is looking at your vaginal lining, making sure everything looks good in a way that you can't really tell yourself. But maintenance at home is done by women unless they have maybe, sometimes there are issues with like hand strength or reach, or some pessaries are just awkward and weird, and maybe some women have like a finger to vagina length ratio problem. Most women can maintain them at home themselves.
So we do have one comment here in the Facebook chat for a question for you. And Nancy says, what can I do if my medical oncologist prescribes an estrogen blocker after my breast cancer surgery showed my cancer is estrogen receptive? So going back to the estrogen question and how that affects everything possibly.
Right. So Nancy, that's a question to talk to them about. And that's really my main suggestion is have those conversations. And if you're able, not every oncologist is going to have specialty knowledge in pelvic health. So ideally, your breast cancer team would know about this because it's super common. They're putting everybody, not everybody, but they're putting many, many patients on estrogen blockers. But if you're not able to have a satisfactory level of conversation with them, try seeing if you can get a referral to talk to a reproductive oncology practice and or a reproductive endocrinologist, someone whose whole specialty is in sex hormones, basically. And those practitioners might need to talk to each other because each specialty is so deep. There's so much information out there. No one specialty can know everything, but keep asking is the thing. And there are it depends on what your concern is too. Like if your concern is your connective tissue, really dial in on your diet, which you want to do anyway with a history of cancer, or anyone. We all want to be eating a really, really healthy diet. If your concern is issues with the vaginal lining, then you'd want to have conversations about that and what kind of moisturizers or lubricants might be helpful for you and what would be safe for you. So I don't want to go too far down that rabbit hole, but the main thing is really, really talk to your providers and see if you can get connected with maybe a couple other specialties if you don't get the detail you need.
I hope
Yeah,
that was helpful. Thank you.
Yeah, she mentioned that she does have a vaginal prolapse, so that is a concern for her. But I think that following through with all the advice that you just mentioned is a great place to start.
Yeah. Any comments on that, Hannah?
No, I totally agree. I mean, there's, like you said, the specialties are there, and we don't want to, cross barriers of giving advice when we don't know the details for someone.
So it seems like a non-surgical method is to treat with a pessary. Is there another method?
So there are treatments and there is management. So I have a lot of women in my program who don't want a pessary, or maybe one of my big things is I'm talking women into pessaries all the time because I see how they really benefit women.
Okay.
But some women don't want a pessary. Some women have had a bad experience with a pessary. Particularly some of the other shapes and styles of pessaries are more difficult, or maybe they had one bad fitting experience and it was really painful. Those things do happen. So some women are reluctant to use a pessary, and then you would go to really your treatment options then are limited other than Arvigo therapy or surgery. But there are lots and lots of management options. And for example, there are loads of different kinds of external supports that women can wear. So, if you had your prolapse to your knees, fortunately, we have more resources than folks we were talking about earlier. But you can buy special braces that help hold everything in place. Being really, really deliberate and careful about your exercise program, being really deliberate about your body mechanics and the way you sit, the way you pick things up off the floor, the way you stand and walk. All of those things have an enormous effect on prolapse. And even stress, emotional stress I don't have an explanation for it. On a day-to-day basis, stress can have an enormous impact on prolapse. I just talked to somebody who, a woman in my program who said, while I was on vacation, my prolapse was great. Now that I'm back home with the stresses of my life here, my prolapse is worse. And it makes sense. You know, stress has specific kind of chemical effects on our connective tissue. Like I get how inflammation and stress and cortisol are have the ability to affect us long term, but literally one day to the next, our emotions can affect prolapse. So practicing those stress management tools is never a bad idea, just like eating right and, you know, exercising safely. It just never ceases to you know, we just see over and over again how many times the solution to something is eat right, exercise right, sleep properly, manage your stress, you know, all that
Yeah.
same old boring stuff. It
Yes.
really matters a lot.
I think sometimes people look for the magic pill and it's like you haven't even dialed in the basics yet.
Yeah.
You know, and let's talk about those things first and get those optimized before we look at popping a pill. At least as health coaches, weight loss coaches, you know, nutrition coaches and personal trainers, that's what we see. I'd like to talk a little bit about, you know, surgery versus non-surgical methods. So like what is the surgery like for this? And did you say earlier at the top of the call that 1 in 5 women get surgery for this?
Yes, for either pelvic organ prolapse or urinary incontinence. 1 in 5.
Yeah.
That is insane. And how many women do you know who had that?
Yeah, no one. Well, one.
And how many do you actually think you know who haven't mentioned it to you?
Oh yeah, many more.
Probably a lot.
It's really, really, really common. So what was your question, Adele?
So can you explain the surgical
the
approach,
surgery.
and then we can talk about some non-surgical methods and maybe what you offer, which is a non-surgical approach. That would be great.
So the interesting thing about this surgery, and I had never thought of it this way, but a friend of mine who is an holistic and integrative OBGYN pointed this out, that she said, and now they're trained as surgeons, right? OBGYNs are trained as surgeons. It's a big part of what they do. And she said, if you notice, there is no one good procedure for pelvic organ prolapse. And I mean, there wouldn't be anyway, because there are different types, right? We would expect different procedures for the bladder versus the rectum and so forth. But she's just for the bladder. If you start looking around on PubMed or, you know, whatever internet, there's a huge range of different approaches. And she said, from her perspective as a surgeon, she pointed out the fact that there are all these different procedures to achieve the same outcome tells you that there isn't one that's really great. That was a huge light bulb for me.
Right.
Because I know that these surgeries tend to have really high complication rates and really high failure rates and really high repeat surgery rates because it's tricky in there. It's really tricky in there. And it's like if the connective tissue is failing, you're trying to shore it up, and it's like sewing a Kleenex or something. It's not, there's no sort of really easy, it's not like you know, take your gallbladder out and seal off the duct and it's over. It's complicated in there. So there are lots and lots and lots of different procedures, and you know, of course the most kind of infamous thing is these mesh procedures, which have resulted in a whole lot of problems for women. So I don't try to keep up on the specifics of surgery and all the, you know, I'm acquainted with basic stuff, but I don't make an attempt to keep up on all the different procedures because I'm specializing elsewhere. There's only so much room.
Yes, on the hard drive. Yeah, I get it. Hannah, do you have anything you want to add to that about surgeries for this?
Yeah, I mean, I was a surgical and PACU nurse before I worked in women's health. So I've seen my fair share of the good, the bad, and the ugly with these surgeries. It's several patients and procedures that I've cared for popped into my head of either good or bad outcomes. So it's not that it's a bad option for everyone, but totally what Alice said, like it's so complicated, and um, it could be a great option for somebody that they've just tried everything. But I would definitely say, like, just to the audience listening here, our goal is not to make anyone afraid of anything in particular, because we are not the doctor saying do this or don't do that. But our encouragement as coaches and professionals is to approach from, my take is always to approach from the least invasive first, right? The least invasive method and the simplest method first, because it could be something like nutrition and better exercise. Okay, maybe it needs to be more specific. Maybe it needs to be going to, PT for the pelvic floor. That is very effective. And there's just a lot of options that maybe seem more complicated or time consuming, but in the long run, surgery might seem like the quick, easy way to go. But when you look at the complications and the repeat surgeries, that could end up being lifelong, like things aren't quite right still. So just to encourage our audience listening to really take into consideration where your physical body is at, and starting with that simple, least invasive method for sure.
And the thing is, too, Hannah, I agree with every single word that you just said. And the thing is that even if you have surgery, you still need to do all the other stuff
Exactly.
because you're still at risk. It's not like, oh, I had the surgery, now I'm going to do CrossFit.
Right. And there might be the tendency for someone that's had surgery to think, oh, good, it's fixed, I'm done. Like, and then there's still no lifestyle change, which is even more detrimental, because surgery causes weaknesses in your body
Right.
in other ways, like that you didn't, like any kind of surgery, you're going through muscle tissue, you're going through that, then creates scar tissue. Like there's just so much involved with that. And people just, again, sometimes are not informed about that even by their surgeon, unfortunately. And this just goes back to my hard, fast rule of self-advocacy. Like we have to ask good questions. We have to be informed and make good decisions for our bodies as each person, like individual. I'm all about like making that decision for ourselves, being informed though, informed decision, like
Yes.
100%.
Yes. And I want to just absolutely, like everything you just said, I want to engrave on a plaque and put it behind me on the wall. And I want to add too, like I'm not, as you said too, I'm not anti-surgery. What
Right.
I'm opposed to is surgery presented as the only option or the first option.
Right.
What we want to do is try the other things first. And
Right.
the crime is that doctors who begin their training as innocent people who want to help, by the end of their training, they end up heavily influenced by the messed up system they're practicing in,
Yeah.
with its limited patient time and all the other economic stuff. For a doctor to do pessary care costs them money.
Mm.
So what's their bias going to be? Are they going to be like really advocating for
Nope.
pessary care that sometimes takes multiple fitting sessions and more maintenance time and longer visits? Or are they going to be advocating for what they can do in a 7-minute office visit and for something they get paid for, like surgery? And it is a crime that our system is set up that way.
Yeah.
But that's
Can
how
we
it is.
can we talk about some of your non-surgical approach and Kegels, and maybe a bit more about your program?
Sure. So, PT is a great option as long as you have a really good PT. They're not all created equal. And if you're going for pelvic floor PT, you really want to see a specialist, not somebody who does head to toe everything else and your
Right.
pelvic floor too. You want to see somebody who really, really is a specialist in pelvic floor and has a strong reputation in the community as being the right person to see. So the thing that happens, and I've taken off the outer layer here, whoops, it goes that way, but pretend that layer is still on. So the pelvic floor is this bowl of muscle here, and with the organs, well, we lost it. With the pelvic floor there, the organs are falling this way. And when the pelvic floor, when you're doing Kegels in a therapeutic way, which is not, and you know, the three of you and your audience, you know better than anyone, you can't just, if you want certain outcomes with your muscles, you have to exercise them in a specific way. And your pelvic floor is no different. So when you're exercising the pelvic floor correctly, which in my 14 years of teaching women this, 99.99% literally are doing Kegels wrong. But when you do them correctly, you're doing a number of things. The pelvic floor is becoming thicker, it's becoming more firm, it's moving up toward the center of the body. And another thing that's happening is, remember our friend, this gap in the muscle here, the urogenital hiatus, that the prolapsed organs are actually falling through. The urogenital hiatus gets smaller. So all of those changes help to support your prolapsed organs better. The ligaments, of course, are not muscles. We can't exercise them. So we focus on what we can do, which is to these muscles way over here, is to work these muscles. So that's, and that's just with prolapse, you know, which we think of as a mechanical thing mostly. Then there's there's incontinence, there's better sex, there's the support for the base of the spine. There are all these other things that change when you're doing therapeutic Kegels correctly.
You know, it makes sense to think of it as a muscle, because I was thinking about triceps, right? Triceps, how you can get these bat wings if you don't actually work out your triceps. And when you work them out, they do get fuller, as you said, and they move up. They don't just hang. You said a third thing, they get fuller, they get thicker, something like that.
More
Bigger,
firmer,
right.
Thicker, and in the case of the pelvic floor, higher up. They move in this direction. The whole bowl lifts, and then
a muscle.
Smaller.
It's a muscle. And I imagine, I'm thinking, you know, in terms of muscle development, it's good to have a higher protein diet. It's good to have the collagen, stuff like that, because they're the building blocks of, you know, muscle tissue.
Yeah. And now these muscles, these are small. This is life size here. This is not pounds and pounds of muscle.
Yeah. So could you chat a little bit about your program, like how many minutes a day it is and the exercises and that kind of thing?
So with my program, this is one of the things that a lot of women are really missing the boat on with Kegels is, you know, you can't do therapeutic Kegels correctly based on one paragraph in Cosmo.
Really?
Cosmo knew everything.
So really learning actually how to do Kegels correctly and every parameter of how to do them correctly, with when and how many and how much and how do you breathe and what body position do you use, and all these, there's a lot to it. And my program, the how-to portion of my program is 2 hours of training. And you'll notice that's a lot more than you'd get in a 7-minute doctor visit as well. So the 2 hours of training is really, really, really important. And if you want, we could do one really good Kegel here.
Sure.
Together, if you want to do that. It's a little sample.
But yeah, let's do it. And nobody
so-
has to know, right? We
Yeah. So, and that's another thing. That's another big Kegel mistake is like if I'm at a party or something, if I meet people, often women are like, oh, I am doing some right now. I'm like, and you're not doing them right. If we're
Okay.
having a conversation and you're doing Kegels, it's not correct. So, all right, let's do one really good Kegel. We're going to do the movie star exercise.
Okay.
So, close your eyes and imagine that you're having dinner with your favorite movie star. It could be someone who's not a movie star, someone you really want to impress. I always like to think of Denzel Washington around age 40. So you and Denzel or whoever are having dinner. You're in a very quiet, secluded corner of this restaurant, and Denzel or whoever, this person is really starting to open up to you. Like they're really revealing a personal story that's really meaningful. It's really getting, conversation is really getting intimate. And all of a sudden you have to pee and pass gas all of a sudden really bad. So hold it in, hold that back with everything you've got and let it go. So exercise over, you may open your eyes. What you notice about that, it's not 200 of these that are red light, right? You're doing strong contractions. You're doing a maximum strength contraction. You're engaging not only the hold your P muscles, but the hold your gas muscles. Because if you look here, the biggest, here's the outer layer, the pelvic floor, right? This is more, there's a little more hold your P action going on here. But the other layer, the biggest, strongest part of your pelvic floor is these muscles called the levator ani muscles. It means lifts the anus. So if you're not engaging your anus, you're not doing it right. So we have strong contraction, the whole pelvic floor. We want to do a sustained contraction, not pulses like this, but a sustained contraction. And we want to relax consciously and completely after every single one. Those are absolutely key parts of doing a proper therapeutic Kegel exercise. And, you know, there's a lot more to that, but that's some of what
One
can
of the
be really helpful.
exercises in your program. And so how many minutes a day are people supposed to spend on these exercises in your program?
So my program is Kegel Success in Minutes a Day. And it's just a very, very short, you know, it depends. If you want to take more time to relax, it can take longer, but it really is just a few minutes, a few times a day.
Wow.
And once you're through that 2-hour how-to, it's really simple. Women like to do it first thing in the morning, last thing at night.
Yeah. And you have a lot of testimonials, and some of these women have been able to avoid surgery doing these exercises.
Yeah. And you know, and I want to shift the perspective. Every time we talk about surgery, women come into the program and they're like, will this help me avoid surgery? Can I avoid surgery with your program? I'm like, you can avoid surgery without my program. Like, this surgery is a choice that you make, and you may do my program and have surgery. That what we're going for is, what I want to help you do is optimize your pelvic floor and create a management plan that includes everything else that you can do, everything that can be helpful to you. And if for you surgery is part of that down the road, then I have some things to say about that too that might be helpful. But I really want women to And also because there's no guarantee with this, in my program, typically women tell me my prolapse is better. They say it's not out of place as far, it's not out of place as often, or the yucky sensations go away, or they're not as bad. Maybe all three, maybe two of those things. Some women have no benefit at all.
Mhm.
And some women say, the doctors can't find my prolapse. That's unusual. And it's also very unusual for them to say, nothing changed. I did everything religiously and nothing changed. But how much is any specific woman going to benefit? I don't know. There's a range. And if I had a magic wand that could do, bring about 100% cure for everyone, I would love that. But
there's never 100% on any program or any medication even, and there's always outliers, and there's so I think that's very honest of you to say that. But how long does it take usually for women to start feeling better with your program, where they actually notice a difference? What's the feedback?
It depends on what they're doing, what they're there for. For better sex, that could start tonight. For urinary incontinence, a lot of women start seeing changes in about a week because simply because of better control. They haven't had time to do the like muscle mass changes like we were talking about. Just better control can help in as little as about a week for incontinence. Then for the real muscle changes, the what we were talking about, like with the mass and firmness, that is weeks. So I have had women who say, my prolapse is better the first week. That's unusual, and I honestly can't explain it. But generally, a couple of months, 6 weeks, 2 months, sometimes longer, depending on what else is going on. Like if you're doing maybe Kegels perfectly, but exercising in a way that's counterbalancing, that it's working against you, or you have other kind of body mechanics issues, or you got a bad cough, or maybe there's also a learning curve where some women already have the ability to contract and release the pelvic floor. Other women have to learn how to connect their brain to it at all. And so there's once you're doing really good Kegels, though, 6 weeks to 2-3 months for prolapse, most women, unless there's something else going on, most women are going to start seeing effects there.
So we do have a question here in the comments. Joan, our amazing Joan, she did the Kegel exercise with us. She said she's just wondering if it's normal to hold your breath whenever you're doing the Kegel, because she felt like
yes, that is a common response to Kegels, and something that I want to train you out of. Breath holding, generally, not a great thing. I really want you to keep the breath moving while you're holding that contraction. And then our breath is a great tool to help relax the pelvic floor afterwards. But while you're holding, I want you to keep breathing.
That's a great question, Joan. I know Hannah has to run. Hannah, thanks for coming. It was great having you here today. I have a few more questions if you don't mind, and we can also check the comments for more questions. Yeah. Okay.
Hannah.
So my other question is, so then how do Kegel exercises help you have better sex?
Well, I love talking about this. For that,
we all do.
This part of the pelvic floor to come back in position here. All right. So we're missing the other layer, but this is the outer layer of the pelvic floor. The sun never shines here where I live, like this.
I thought you were going to say the sun never shines here.
That's true. That's also true. But I'm like, yeah, I don't usually have to deal with this sun shining on my everything while we're talking here. So let's get oriented again, right? So here's the vagina, anus, and here's the clitoris, okay? So I don't know how well you can see.
Yeah, that's good. Can totally see.
There are many, many ways that Kegels help with better sex, and there's a muscle thing. So there's a specific muscle thing. So one thing is all those thicker muscles with better circulation. Better circulation is really, really important for sexual function. And one of the things about sexual sensation is when you have an orgasm, you're experiencing contractions of these muscles. And if you have nice, strong muscles, those contractions create more sensation.
Oh, okay.
These muscles also, especially these way over here, these provide structure for the vagina. So more sensation with intercourse when these muscles are firmer and thicker. Also, better muscle control allows you, because here's a sex thing anybody can try today, is just play with contracting and relaxing the pelvic floor during sex. Any way you want. Strong, light contractions, strong contractions, sustained, brief, deliberate relaxation, anything. Just play with it. And this can create a whole different kind of sensation to explore. But what I wanted to show you with these muscles is these muscles right here, called the bulbocavernosus muscles, are attached to your clitoris. Most of us, didn't learn anywhere that we have muscles attached to the clitoris, but we do. And if you deliberately contract and release these muscles, you can actually move your clitoris. It's just a little bit of motion. It's just a little bit of motion, but there are a lot of nerve endings happening there. And by deliberately moving your clitoris, you can increase the level of stimulation that you're experiencing no matter what you're doing.
That makes perfect sense. When I took kinesiology and we had to take anatomy and learn all the bones in the human body and the muscles, that was never brought up. Yeah. Interesting. I've learned a lot today. Tiffany, do you have any questions?
I think that one of the questions that I really wanted to ask you was about common mistakes or myths that you see women making or believing when it comes to their overall pelvic floor health.
So many. And I guess really the first mistake is, and none of it's anyone's fault, but the first mistake is culturally, we don't talk about it. We don't talk about prolapse. Certainly we talk about sex more than our grandmothers did, but still we're not, this is, the sun doesn't shine there. And so just bringing the conversation out is one of the most important things we can do, and talking to each other about what's actually happening. That's huge. And, it's not anyone's fault. We're so undereducated about spotting these problems, all the things we were talking about before, that, like, how would you know that you have something going on? And then with Kegel specifically, it blows my mind how much misinformation is out there. It's like more than the proportion of bad information is just super, super high with Kegels. And I still don't really understand why, because it seems like more than just because it's down there. But you can't do effective Kegels at a red light. You can't do effective Kegels based on one paragraph in Cosmo. You don't need a device. That's another whole topic we could talk about. Everybody on the internet, if you look it up, they're going to want to sell you any number of devices of all different kinds, electrical ones and ones with an app. And there's, you don't need them. And just women don't even know the questions to ask. And it breaks my heart, really.
I really appreciate your time today, Alyce. It was fantastic. If anyone has any questions, we'll be monitoring the chat, and Alyce can pop in and answer your questions, or we'll do our best to answer your questions. if you're interested in more information, then Alyce has a webinar. It's free to register for it. It's called How to Beat Prolapse Surgery and Stay Out of Adult Diapers. And there are 11 tricks that might surprise you. And she also has a free exclusive report, 5 things you didn't know about your vagina after 50. You can check out that webinar, and I will link to it in the comments on, below. So definitely check that out if you'd like more information about Alyce's program. All right,
Thank you
anything
so
you
much
want to
for
say,
having me.
Alyce?
I am just so glad to be here and have the opportunity to help women bring this out of the shadows. And I'm so glad to meet you. And thanks so much for having me.
Thank
Well,
you.
we
It was
loved
wonderful.
having you.
Yeah, it was wonderful. Appreciate it. Thanks for all that you do. All right, take care, Alyce. Bye, Tiffany.
Bye.